So one of the things that I'm very happy about at looking at this symposium is that there are a lot of very, very young people. There were a lot of young people in the room. So let me start by making a rather pessimistic statement, but I think this is important for young people to understand what needs to be done in the near future. So when you look at the disease and you consider a disease as a planet or as a fruit, if you want, there are several levels at which you can intervene in order to make your patient feel better or possibly get rid of the disease. So you can just scratch the surface and get rid of the symptoms. This can be done in most patients, fortunately, and this is already quite a lot you can do. It's the very least you can do, but then the next step is to probably stop the progression of disease, so the consequences of the full-blown disease on outcome. And this is harder to do, as you know. And then we can do what Caroline Ho was saying. We can try to stop the development of disease, of the full-blown phenotype in patients who are predisposed to disease. And finally, you can act on the etiology of disease, so remove the cause and actually cure the patient. Well, the bad news is that cardiovascular medicine is still palliative medicine to the largest degree, with the exception of the boring part. So if you treat hypertension, you treat diabetes, exercise, get people thinner, that's the only way you can probably cure the cause of disease. Otherwise, everything else is treating the consequences of disease. You can't tell this to interventional cardiologists. You can't tell this to most surgeons, with few exceptions, because they think they cure people. But in fact, we can treat people, which is the least you can do. Again, you can get rid of the symptoms, use your drugs. We can manage patients, which is something better than just treating them. This means we can use our diagnostic tests in a clever way. We can think of new ways that are off-label to make the patient better. We can withdraw treatments that we think may be not appropriate. And so this is what really makes the difference between a man and a computer: management and care, obviously. Care means putting some humanity into this as well as your skill. However, we cannot cure most of our patients, and this is something we have to keep in mind. Although, as I said before, palliation can be effective. Palliation, I have nothing against palliation. We can do some very good things with palliation. Stents are palliation, but they have changed the outcome of patients with coronary disease. Pills have done a lot for patients with heart failure, with cardiomyopathies as well. And obviously you have surgery, you have ICDs, and you have VADs. What usually palliation does, it changes one disease into another. And we have some very good examples. For example, septal myectomy turns hypertrophic obstructive HCM into non-obstructive HCM, and this is quite a change for the patient, quite a change to the better. So it is something we should keep on doing better and better, and this is not trivial. However, curing is different. So what is really not going well in terms of treating cardiomyopathies is that we are not really trying hard enough to use the large amount of information which Caroline has beautifully illustrated for us, and to turn it into sound clinical questions and start accumulating the data that at present time will only be useful for halting the progression of disease, but in the future time possibly something better. And this is, for example, a research priority report of an NHLBI study group on hypertrophic cardiomyopathy, but many of these concepts I will refer to are related to HCM, but can be easily applied to any other genetic heart disease. And what it says here is nearly 50 years after the identification of HCM as a genetic disease and 20 years after its linkage to sarcomere protein disease, mutations, we still do not understand the most proximal mechanisms that initiates the disorder. This is what Caroline has told us, and a lot of what she has said is very instrumental to what I need to say, so I thank her particularly for this. She has said that beautifully. And the fact is that treatment recommendation, as we all know, are based on personal experience, limited observational series that are usually not controlled, not prospective, and non-randomized. So it is based on a very impressive, useful, positive bulk of personal experience, somehow structured into data, but we are very far from evidence in treating these patients. And furthermore, we do not have certain elements that will certainly change the outcome of the patients, with few exceptions. So, and the report also very honestly outlines what the limitations are, because we all know why is it we don't have the evidence that people have for ischemic heart disease, for heart failure. Well, this is because, of course, the epidemiology is a lot different. These are not as common diseases. However, these are not rare diseases now. I mean, we know that the epidemiology is changing, and as Caroline has shown, if you look for the disease, you will find a lot of disease. Some of this will be subclinical, so you even wonder whether you should raise the issue on somebody who's perfectly well and only has a mutation. However, the disease, the real disease, is definitely more common than we could hardly imagine just 20 years ago. Another big problem is that the disease doesn't come in prototypes, doesn't come in stereotypes like myocardial infarction or some aspects of heart failure, if you want. But each of these diseases, particularly HCM probably, really has phases that are totally different. And you cannot put patients on trials if you can't compare the pre-hypertrophic phenotype with the end stage, or the obstructive versus the end-stage patient. So you need to think of trials that will be targeted, tailored to specific subsets of diseases that are not common, and you end up with small numbers. So you need real huge networks for this. However, we are getting there. We are beginning to have networks that have the numbers to build up into meaningful, potentially meaningful cohorts that will allow data, allow studies, including outcome studies. So this is not the best excuse anymore. It used to be. This is now changing. Also, there are cohorts that fortunately have very low event rates. So if you want to look at outcome in somebody with a classic HCM phenotype, but also early ARVC, for example, you will not be able to detect any difference in survival, for example, unless you have real huge numbers and long follow-up periods. And the value of the surrogate endpoints, which we have been using, like non-sustained or ventricular arrhythmias, prevalence of fibrosis, remodeling of the ventricle, progression of disease in terms of symptoms, exercise capacity. These are all endpoints which we don't know how relevant they may be to outcome. So we can use them, but we have to know that these are limited. And last but not least, there has never been a strong economic interest from companies in sponsoring trials in this disease, again, because of the small numbers and because the drugs that we are using or we want to use are not expensive. So I wonder how many of you know how little pharmacological research has been done, for example, in HCM, which is it's easier than dilated, because dilated obviously is not a clean model. Dilated cardiomyopathy melts with heart failure trials, and it's always hard to know how many truly idiopathic dilated patients are in the heart failure trials. So, for example, HCM, which is a clean model, we recently reviewed the literature with Paolo Camici and Mari Meron and Roberto Spoladore, and it came out that in the last 60 years, so since the description of the disease, there have been a total of 45 studies performed, enrolling an average of 35 patients per year. And if you look at the last 40 years, there is no increase in the number of studies between these 2 decades and the most 2 recent 2 decades, and the size number of these studies obviously is very, very small. So we are not putting any increasing effort in our pharmacological research, despite the wealth of evidence, the increasing amount of basic research, and the incredible amount of data that people like Caroline Ho and other groups are offering us from the labs and the clinical research settings. Furthermore, this is not a big surprise. We are still using, for treatment of these highly sophisticated diseases, we are using drugs that are, again, palliation medicine. They are effective. I'm not saying they're not good. I think some of them are very good, and we can really use them very well. Some of them may be lifesaver, although this is hard to prove. However, these are all 30 to 50-year-old drugs. And there is nothing really major in sight that can change this, despite all we know about basic research in this disease is because there's no active research going on, basically. And I will spare you a lot of this because Caroline went through this, but we have some very, very nice targets which we can think about. And she already talked about the calcium cycling sensitivity. Again, this applies to dilated and hypertrophic, although it goes with different signs, plus or minus, depending on which model you're looking at. The fibrosis, which is incredibly interesting. This is a disease that is almost a constant of cardiomyopathies, no matter which model you're looking at. The altered energy homeostasis and the biomechanical stress sensing. Each of these targets here can be directly targeted by drugs which we already have, like calcium antagonists here, like angiotensin II or sartan antagonists, and statins. We have, Caroline again has shown this, we have some relatively convincing preclinical evidence from transgenic models, for example, and some human data, but that is not as convincing. So these are all drugs we can use for novel indication. Again, we're not talking about treating heart failure in these patients. We're talking about preventing disease progression or even disease development. So it's not the drug that you want to use, it is the stage at which you want to use it that make a difference. Then there's a whole problem related to the genesis and the effects of microvascular function and how we can treat it. And Paolo Camici will talk about this tomorrow, so I will not get into this. This is also very intriguing and potentially very relevant, not only to hypertrophic cardiomyopathy, but virtually any cardiomyopathy, and also left ventricular hypertrophy from all the other causes, such as hypertension, for example. So if we can solve the riddle of treating microvascular dysfunction in a model like HCM, for example, this will have huge consequences for other more prevalent conditions. And so this is a very nice target for research. So what do we have? One of the approaches that has been used with some success is to try to correct the energy deficiency. For example, this again is HCM, by shifting fatty acid metabolism to glucose utilization by the sarcomere, and therefore enhancing the efficiency of the cardiomyocyte. This has been done with an old drug by the London and Oxford groups. The drug is perhexalin. This is a drug that is quite old, can be hepatotoxic in a minority of patients, and is also not marketed in Europe and US. So the nice thing, it showed an increase in exercise tolerance and an improvement in symptoms in patients. This was a very nice randomized double-blind study, so very well methodologically conducted study. This is the sort of thing that we need and of which we don't have much. However, it is possible that this is not the best drug we can use in the future because of, again, it being an old molecule. I believe there may be. We should look for molecules that can probably do the same job but have less side effects and probably do it better. Then there is something that is more like science fiction. So there are small molecules which can bind to specific proteins such as myosin and turn it on or turn it off. So you can activate myosin if you have hypokinetic, if I have a hypokinetic problem, and try to improve contractility. However, if you have a very highly contractile and poorly efficient engine, like in HCM, for example, you may want to do the opposite. And there are now molecules that are beginning to surface that hopefully may sooner or later try to do this in a selective way by binding to defective myosin without, for example, interacting with the normally functioning myosin or skeletal muscle, for example. So this is something that would be nice to have, and there are some human data on this. So you can see that, for example, omecamtiv mecarbil is a drug that does exactly this. Is a myosin activator that can increase systolic function in heart failure and in healthy individuals. However, this is probably still to come. So I just want to talk briefly about our own little Italian Florentine contribution to this debate, to this process, which takes a lot of work, but I would like to tell this tale to you because I think it's a nice tale. You've heard about it in the mini course, those who went to the basic science, but basically we know that if you take the cardiac myocyte from myectomy samples and you study its electrical remodeling, what you can see in vitro, and this has been done by Federico Pini in Elisabetta Scelbai's lab and Alessandro Mugelli's lab, you can see that these cells have an electrical phenotype, an electrical remodeling. These are patients with HCM and sarcomere mutations, and this is relatively independent of other parameters measured within the cell. And what happens is, as in other models of heart disease, when the repolarization is prolonged, is markedly prolonged, you have early after depolarizations coming up, which are triggers for arrhythmia, so are a risk marker for arrhythmia. And they also went on to see that this effect was due to an impaired activation of the late sodium current, for which, and this is again not specific to HCM, but it was very markedly abnormal in HCM. So the degree of the abnormality was really striking, and this was not a failing heart. This was a hypertrophic obstructive, highly contractile heart. Fortunately, we have a blocker for this, which is a drug that is currently marketed for coronary disease, for angina, and this did very nicely diminished and almost normalized some of the alterations that you see here in red compared to the non-treated in vitro model. So what it also did, and we know the drug does this in several models, it reduces the calcium overload in diastole, therefore improving diastolic function. So that for a number of reasons, it turned out that ranolazine could be a very advantageous drug in a model like hypertrophic cardiomyopathy. So the next thing would have been, let's give it to 50 people and see how it goes. And fortunately, this is the way it would have normally gone. And fortunately, we did find support for this, and this is my conflict of interest, which I had to declare with Menarini. They decided to embark into this, and they helped us design a randomized, multicenter, double-blind study, which will, at the moment, just focus on exercise capacity. And we are looking at present at whether this drug can do something good at patients, looking at exercise capacity as well as arrhythmias, symptoms, quality of life. So this is one small step for man, but giant step for humanity. And I conclude here by wrapping up saying that it is quite obvious that genetic cardiomyopathies remain orphan diseases. We do not have the right drugs to do whatever we can to prevent disease development and to stop progression of disease. We need to do more research on this, specifically targeting the pathophysiological targets we have found after so much basic research. And we need to move cardiomyopathies into the era of evidence-based treatment. Thank you.
So I will start. Caroline mentioned some of the new treatment, actually all treatment, like calcium channel blockers, and you mentioned the new drugs that may be novel drugs for hypertrophic cardiomyopathy. There were some studies in the past about other type of compounds, like statins, angiotensin converting enzyme, inhibitors, and that pathway. Can you comment on that?
Yes, so there's the group of Ali Marian in Texas. They were able, using statins and sartans as well, to sort of pretty much see what Caroline was also referring to. So sort of you can blunt, to a certain extent, the development of a phenotype in transgenic. I think it was rabbit in both cases. And this was a promising thing. However, when they tried to do this, the Ali Marian group tried to do this in humans. They treated some genotype positive patients with statins. And this becomes an impossible thing to do just unless you really have large numbers and select patients very carefully. And Caroline's, for example, trial had a much more accurate design. The problem is that in human, as you know, in human disease, you never know what age and how severe the disease will come up and how it will be. I remember when I was working in neurology, we had the same problem with multiple sclerosis. You were trying to prevent recurrences, and you would never know whether the patient had a good year because the disease had sort of remitted, or whether. So these data are far from conclusive, and the human data is very weak.
Jacopo, you're doing, I think, obviously the right thing, getting a small trial going and so forth, but if it's negative, do you think there may still be a role for a drug like ranolazine in the preclinical stage? Maybe once patients have overt hypertrophy and symptoms, the horse is more or less out of the barn, and maybe we need to go earlier. But if you have a negative trial, would you have enough enthusiasm to go to a lower stage?
Well, first of all, this is a drug that's marketed already for angina. So it's supposed to be just for people with coronary disease. But I think every one of us has anecdotal evidence. For example, it has helped me very much in a couple of non-HCM cases, a couple of young ladies with normal coronary arteries and very consistent anginal symptoms, obviously due to microvascular dysfunction. There was no other reason for that. So, if at worst, you can use it as a symptomatic drug, which is, if it doesn't show any other. So I think, again, because it's a label, it's a marketed drug, you can use it as a symptomatic. But it has a lot of, potential because of the prevention of atrial fibrillation potential and antiarrhythmic potential, metabolic potential, which is positive, as well as in vitro, we could show that it has some diastolic, positive diastolic properties. So we'll see. We'll see.
Professor Yacoub.
Jacopo, what about atrial fibrillation? You haven't told us about trying to do anything about it, either prevent it in patients with large left atria, looking at left atrial function. It is, you were one of the first to point out how bad a prognostic indicator atrial fibrillation was, but you didn't mention it.
I didn't mention it because there is not much I can say apart from, again, we are moderately optimistic about ranolazine, particularly in association with class 3, because there are experiences in other diseases which show promise. So this is not data on HCM, but it does show promise. Otherwise, as you know, dronedarone has not fulfilled its promise. We are still left with amiodarone as the mainstay. And catheter ablation is, probably somebody talked about this at the mini course, is very interesting. However, it is likely to be effective only when you do it early enough before the atrium is remodeled, and only for this time span. Then the arrhythmia is likely to recur.
We're always targeting the left ventricle. Do you think we are ignoring the atrium and the right ventricle?
You always ask the difficult questions. Yeah, I think so. I don't know how we can target that, though, because it is difficult to. We had a big hard meeting yesterday. There was talks about studying the effects of pressure overload in the Imperial group. Steve Marston had some nice data showing the effects of pressure overload on the left ventricle. I think we should start looking at the right ventricle as a model of sarcomere mutation in the absence of pressure overload, for example, as a sort of control.
I have another question, Jacopo. Do you think that, would you expect, because it's too early to probably know this, but would you expect that different genes or different mutation will respond differently to a specific therapy?
I love you, because this is a wonderful question for me, because this is I always say this, and I didn't want to say this again because it gets boring. This is probably the next very good question for genetic testing. The very good reason for doing genetic testing is that unless we know exactly what the disease is caused by, and what we can't compare pears and apples. So if we want to use drugs that are specifically targeted at pathophysiological mechanisms in HCM, we need to have a genetic substrate. So I think this is another very good reason for genetic testing.